And I'm happy to welcome Professor Imogen Mitchell, who is the Executive Director of Research and Academic Partnerships at Canberra Health Services and Australian National University, and an intensive care specialist at Canberra Hospital, Australia. She will be speaking about Australia's experience of COVID-19 workplace safety. And again, I welcome Professor Mitchell. Over to you.
Well, thank you very much for inviting me to your wonderful meeting. I thought I'd give not only an Australian overview of COVID, but also my own jurisdiction, because a number of jurisdictions in Australia did slightly different things. So as people may recall, Australia is sort of down in the Pacific, and I'm speaking from Canberra, which is in the Australian Capital Territory. And you'll note that Australia is a federation and it has 8 jurisdictions. Now, if we look back to January 2020, Australia was in fact obviously a large island, the land mass of the United States of America. It's also a federated country with 8 jurisdictions, and each jurisdiction has its own government. And many of the health processes were in fact governed by the local jurisdictions, which I'll explain in a moment. So as I said, it's a large land mass, but actually a very small population comparatively, so for example, to the United States of America. And that's been to our advantage, both being a relatively as an island in closing the borders to try and minimize the amount of COVID coming into the country, but also the density of population was much less than, say, populated areas of the United States. Clearly, there are larger cities such as Sydney, Melbourne, and Brisbane. And certainly Sydney and Melbourne experienced more COVID than other places in Australia, which had far less dense population. So that you can see for about the first 18 months of the global pandemic, the numbers of COVID cases in Australia has been extremely small compared to the rest of the world. And what that has meant is that much of the time during this pandemic, many of us, although not all of us, have really lived an existence that would be no different to every day of pre-COVID. But you can see that the numbers of cases beyond December of this last year, they've gone up. And the reason for that is that Australia has done extremely well, although rather late coming to vaccinations, has done very well in terms of getting most of the population vaccinated. And then there was a decision by most jurisdictions to open their borders once there was a population over the age of 16 who were 80% double vaccinated. And it was only then when the borders started to open both domestically and internationally did we start to see the increase, and a particularly large increase when Omicron came across our shores. But even so, the small number of cases, if you like, through suppression of testing, tracing, and quarantining, both those international travellers, but then also if people got COVID and those around them were close contacts, there was a 14-day period of isolation such as to minimise the amount of COVID. But as the population became more vaccinated, as the borders opened up, there was more COVID and therefore more hospitalizations. But thankfully, this hasn't resulted in an overwhelming healthcare system, particularly when it came to our intensive care resources, such that now hospitalizations, about 7% of those hospitalizations result in intensive care admission. So we've been very lucky in Australia to really have minimal experience of COVID. And just to explain why there's been sort of differences amongst the jurisdictions, and particularly when it comes to managing healthcare workers, we had a national governance arrangement whereby we had the formation of national cabinet with representation from the 8 jurisdictions. They were very much advised by a national committee, the Australian Health Principal Protection Committee, which was chaired by the Chief Medical Officer of Australia. And there was obviously members from all the jurisdictions around Australia who really guided much of the decision-making when it came to managing COVID, although not all of it. And then there was also some funding that was shared between the federal government and the jurisdictional government so that no jurisdiction was overwhelmed. When it came to jurisdictional management, they all declared health emergencies. And from that, the chief health officer of each jurisdiction would manage both the public health response, but also the clinical response. Some of that was devolved to the CEOs of large hospitals. But again, each jurisdiction was being guided to some degree by the Australian Health Principal Protection Committee. And all the acute care facilities started to plan for a surge in patients, which we were thinking that we might experience as we watched the United Kingdom, Italy, and New York in particular. As I said, each jurisdiction had their own clinical response and public health response, but what that also meant is they also very much dictated the movement in and out of borders. And interestingly, the borders had not been closed between states and territories for about 100 years when the previous flu epidemic or pandemic was apparent. And so borders were closed from time to time. Aged care facilities were also managed by the local jurisdictions and who also managed hotel quarantine and home quarantine. Each jurisdiction would have developed guiding principles. And as I said to you, each jurisdiction also had capacity plans for their hospitals. And there was a very strong communication process between public health and also the community. So I'm probably now going to talk a little bit about my own experience as the clinical director for the Australian Capital Territory, which is a small jurisdiction, but surrounded by a large jurisdiction, New South Wales. And so to some degree, what we did was very much mirrored by what our larger jurisdiction, which of course had Sydney within it, and therefore a much larger and denser population, which is more likely to be exposed to COVID. And again, if you look at the timeline of events from the first case in Australia back in late January 2020, there have been numerous COVID outbreaks, which was then subsequently treated by lockdowns of varying severity. And the jurisdiction in Victoria suffered, I think, at least 6 lockdowns. So I think they suffered very much from the stress and mental health issues of having this consistent lockdowns. And this also impacted healthcare workers as well, because clearly that impacted their families. And if I look at my own jurisdiction, when we only had 1 case of COVID within our territory, we closed borders, put everyone into lockdown, and we didn't release that lockdown until the population was about 98% vaccinated, which was some 3 months later. And since November 2021, we've had all our borders open. And obviously by that stage, there were international borders open as well. But importantly for our own jurisdiction, we set early on some guiding principles. And these guiding principles were to protect our staff, to protect our patients, and to protect our community from COVID. And these principles have run continuously throughout the whole pandemic. And so what we were trying to do is minimize the harm from COVID, as we've just recently heard about the difficulties of long COVID. Now, we're all familiar with healthcare worker health and safety, and obviously protecting our staff would have been part of this. Difficulty always has been with health and safety, it's been always someone else's problem. And in Australia, this has been particularly true. But now that there is legislation suggesting that if you do not comply with work health and safety, then there are actually going to be penalties and enforcement measures if you don't. So that certainly was, to some degree, helpful in terms of trying to ensure that we did the right thing to our healthcare workers. But clearly, when we're trying to look at protecting our healthcare workers and our patients, we really wanted to try and minimize the amount of COVID, both coming into the jurisdiction, but also coming into facilities which would house vulnerable patients. So what we set about doing when there was a COVID outbreak is that we wanted to minimize the number of footprints coming into the health facility, full stop. And that meant, as I say, minimizing the number of movements across any border. And the difficulty for us is that we're a little island in a large state, and we had about 50 roads coming in. So there's no way that we could easily lock people out, and not least, at least a third of our own healthcare workforce came from an outside jurisdiction. So it wasn't practical either. We also set about minimizing the number of visitors such that they were only allowed in for compassionate reasons. And there was a very strict exemptions process, which I will elucidate a little later. And we also made sure that only the essential healthcare workers were allowed on any campus within the territory. And we were looking after both the private and the public health facilities. So there's a large number of facilities that we're also oversighting as part of the health response. And that meant that we wouldn't have any voluntary staff, and that any people who could work from home had to work from home. That was trying to minimize the number of people coming into these facilities that had vulnerable patients and, of course, had our healthcare workers. We also wanted to minimise the number of footprints that actually had COVID. And there was a very strict exemption process, which included a 14-day detailed travel history, so that we would really try and minimise those that had any contact with COVID at any point in time in that 14 days. And that we would screen every single visitor for COVID-19 symptoms. Interestingly, we never ever tested temperature because we didn't believe that was a particularly helpful marker when it came to COVID. Obviously, when the global pandemic progressed, we became more and more aware of what we needed to do, so that we were filtering air, so those patients who had COVID but were not in negative pressure rooms because we didn't have enough capacity, set up air purifiers in the ward environment. And also when the medihoods came on board, we also provided those for patients with COVID who, again, couldn't get into a negative pressure room. We also started to try and understand that many staff were catching COVID in other jurisdictions in tea rooms, and obviously masks came off, and that they then had to eat and drink. So what we tried to do is to have the tea rooms outside and sort of encouraging people to go outside with vending machines that had free drinks. We also at the same time made sure that right from the beginning, we would reduce the risk of those workers that were vulnerable to COVID, and so that they didn't have to work frontline if they did not want to. So just to give you an example of exemption process. So for anyone coming into the health facility who was from a jurisdiction which was deemed high risk by public health within the COVID area, such as Sydney or Melbourne, depending on where the outbreak was, we made sure that we had a very detailed travel history, such that we then could match that with the jurisdiction from which they came from in terms of where the latest place that had COVID. And this obviously was very helpful that each public health system within those jurisdictions, both in Victoria and New South Wales in particular, were able to trace those that had COVID and the places that they had been to in the previous 2 or 3 days, so that we would identify those that coming into our jurisdiction were at risk of having COVID. And this is a very detailed process, and everyone who came in from those areas had to go through an exemption process. And again, it was quite rigorous because we'd actually have to ask quite a lot of people as to whether these people were actually imperative to come into the health facility, whether they were a visitor or a staff member, and then had to seek various approvals, and then including public health, which then gave them the allowance to come into the jurisdiction and into the health facility. And then just to make completely sure that anyone coming into the health facility, as I say, we had a screening tool that everyone had to fill in every single day that they came into the health facility. And should they receive the Red Cross, then they weren't allowed into the health facility. If they had an exemption form, then obviously they had to present that as well. So we had manned stations that closed most of the access to the health facilities, other than probably the front and the back door, but they all had the screening stations at the same time. So those are just some mechanisms to try and reduce both the footprint and the amount of COVID coming into the health facility. And to my knowledge, not aware that anyone who we put through the exemption process actually brought in COVID. So we've been quite lucky. Now, clearly the next barrier to try and prevent healthcare workers getting COVID was obviously the personal protective equipment. And as we know, there are various forms of personal protective equipment. And at the beginning, I guess, weren't really very clear as to what we really should be wearing. Should it be a surgical mask for droplet spread, or should it be a respirator, because we were concerned about the SARS-CoV-2 being aerosolized? So in this sense, we had to reach out to colleagues around the world, obviously to our own Australian Health Protection Principal Committee. Again, I'm surrounded by New South Wales, another jurisdiction which have a lot of resources in terms of literature and summarizing it. My own university had a rapid evidence unit. And as I say, to some degree, we were guided by those around us and within our own territory. So in trying to work out where we're using surgical masks or where we're using respirators, very early on in the pandemic, the Australian Health Principal Protection Committee decided that only those procedures that were aerosolized should the healthcare workers wear a respirator if they were treating a patient with COVID-19. The rest of the time, that they should just wear contact and droplet precautions. And you will see that some jurisdictions really preemptively started to draw out risk matrices as to what masks they should wear in what conditions. And particularly as the amount of COVID started to increase in density, you can see the slide as you move to the right, there's much more COVID. And so therefore you can see the red squares, which was suggesting that more and more healthcare workers should be wearing N95s. And so there were some jurisdictions around Australia who had very clear guidelines of when you should start to elevate the concern of what healthcare workers should be wearing, and whether there was minimal COVID and therefore not much in terms of wearing masks, to a lot where both patients and healthcare workers were wearing masks. And again, depending on what you were doing, is whether you're wearing a respirator or N95 or a surgical mask. In my own jurisdiction, now recognizing in my own jurisdiction had very little COVID, if any at all, for a very long period of time during 2020, we were really just recommending that surgical masks would be adequate, and that it was only wearing respirators if you were undertaking aerosolizing generating procedures, or if the patient had severe respiratory symptoms or were critically unwell. In some respects, that was a bit of an umbrella, so that gave the staff a bit more of a broader application of being able to wear an N95. Because as you can appreciate, very early on in the pandemic, we were quite limited in our resources, but thankfully, we didn't actually have much COVID at the time. Then there was, a paper coming out from Raina McIntyre's group in the University of New South Wales, who was really suggesting that the challenge that we had is that we were not really basing protection of healthcare workers on the science that was already out in the literature from the original SARS, and that really healthcare workers should be wearing N95s because COVID-19 was an aerosolized disease and not really just droplet. So there was some pressure from academics that really we should be pushing healthcare workers to up the amount of PPE. Perhaps because there wasn't much COVID around at the time, certainly in my own jurisdiction, not every single person was wearing an N95. So there was a big debate around the country where we get about wearing N95s or surgical masks. Our next speaker, I've stolen a cartoon from Professor Moroska, whereby she's very nicely demonstrated the droplet versus the aerosolized, and that suggests a change of whether we should be wearing the N95 or not. If you look back in history, you would obviously recognize that SARS-CoV-1 was spread by the air and indeed probably aerosolized, And then if you look at SARS-CoV-2, there were stories coming out from certainly Acquire in the United States that many people caught COVID and weren't necessarily sitting within 1.5 meters of those individuals. And then, of course, there were cruise ships. And then there were also aged care facilities where you saw healthcare workers who were wearing surgical masks who caught COVID. I think increasingly there was a sense that actually their N95 was critically important for managing patients with COVID. And I think what was very evident in the Victorian outbreak back in August 2020 is that there were many, many aged care workers who caught COVID, but actually pretty much no one catching COVID within the intensive care units where there had been a recommendation that people should be wearing N95s. Of course, the issue that we then had is that we faced unions suggesting not only should people be wearing N95s, but also there we should be fit testing everyone for an N95. Now, this was a challenge to us because not only did we not have the infrastructure to do this, but also there were many people who had not been fit tested, so there's a large logistical issue as well. But certainly the unions are pushing, and eventually, I guess in my own jurisdiction, decided that because the manufacturers of N95 say that you can only wear them safely if you are fit tested, although the evidence of fit testing versus fit checking is somewhat lacking to determine that fit testing is any better than fit checking. But given the manufacturers saying fit test, then she'll put all our healthcare workers through fit testing. And again, these are some data from the Victorian outbreak back in 2020, whereby they demonstrated a large number of healthcare workers being transmitted and catching COVID. And so what they started to do was up the amount of people who were going to be wearing N95. So not only patients undergoing aerosolized procedures or generating procedures, but also there's just point blank, anyone working in the emergency department, intensive care units, COVID-19 wards, aged care facilities. Wherever COVID was cohorted, the healthcare workers should be wearing N95s. And I guess this was the first jurisdiction in Australia who really started to increase the numbers of healthcare workers wearing N95s. In my own jurisdiction in Canberra, we probably didn't see a lot of COVID until August 2021. And at this point, we also adopted what the Victorian healthcare system had done, and that is those healthcare workers who are more likely to be bumping into those patients with COVID. So those, again, in ED, intensive care units, COVID wards, red zones, were all to wear N95s, including a face shield as well. And again, when Omicron started to increase in our own jurisdiction, we also upped it further, such that all healthcare workers, because of the risk of bumping into asymptomatic patients who weren't necessarily coming into hospital because of COVID, but with COVID, we decided that all healthcare workers who are frontline and managing patients full stop should all wear N95s and face shields. And to be honest, to this day, we're still doing the same thing. One of the reasons for this is that we developed a risk matrix exposure, way of managing healthcare workers if they got exposed to COVID. So this exposure risk matrix suggested that if you had an N95 and a face shield, but you incidentally came across either a patient or a healthcare worker with COVID, you actually wouldn't need to be removed from work. We would obviously monitor you. But if you didn't wear an N95 and only wearing a surgical mask, then your risk of having COVID was much greater. So what we were also doing, not only trying to protect our healthcare workers, but also protect our workforce, because over time there has been an increasing issue of losing workforce because of COVID, mostly because of community transition, much less so because of hospital-acquired COVID in healthcare workers. So that was one reason that we upped guidelines, was to try and minimize those people who were exposed to have to leave work and undergo isolation. So when we did an observational review of the exposure risk matrix, those that were in the moderate and had to then isolate 7 to 14 days, depending on the degree of exposure, it meant, we lost healthcare workers, but because of the protections that we were both giving to patients and those healthcare workers, the number of people who actually caught COVID was in fact very small. And even those 187 health staff who got exposed, actually very few developed COVID. So again, we've been very lucky. So in conclusion, it would be fair to say that what jurisdiction did in terms of protecting their healthcare workers wasn't always clear in what was guiding the decisions. The changes in the type of PPE was potentially driven by the number of healthcare workers catching COVID. And I guess there was apparent lack of data determining whether our healthcare workers were kept safe or not. And clearly, when you're very busy in a pandemic, it is sometimes quite difficult to catch data on a day-to-day basis when you're very short of staff anyway. And as I said before, each jurisdiction managed the protection of healthcare workers slightly differently. And there was clearly a very heavy reliance on staff being vaccinated. And so as a nation, it was mandatory for all our healthcare workers to have 2 COVID vaccines to allow them to be in their place of work. I think if one were to review how we could do things differently, I think we need to include a wider base of science so that we are guided not only by infection prevention control experts, but also by a broader group of people who obviously understand airflows and size of particles and the likelihood of aerosolized versus droplet. And on that note, I shall finish with the next slide. Thank you.
Beautiful.